Imagine walking into a doctor's office and just agonizing pain. And, there is a 71% chance you have a specific devastating disease.
Right.
But the medical system is, well, they'll likely make you wait a decade to prove it.
Yeah, an average of 4 to 11 years, actually, which is just unacceptable.
It's completely broken. So today we're looking at how the medical establishment is finally admitting that their rulebook was broken. Welcome to our deep dive.
Glad to be here.
So our sole grounding source today for you listening is the March 2026 Clinical Practice Guideline number 11 on the diagnosis of endometriosis. This was published by ACOG, the American College of Obstetricians and Gynecologists.
Right, a massive organization.
Huge. And our mission today is to unpack this really paradigm-shifting change in how doctors are being told to interact with patients who are suffering.
It really is a radical departure from the status quo. I mean,
Yeah.
for decades, millions of people with chronic pelvic pain have been subjected to that massive diagnostic delay we just mentioned.
That 4 to 11-year gap.
Exactly. And this new 2026 guideline is direct response to that systemic failure. The gatekeepers are basically being removed. The fundamental rules of engagement between a clinician and a patient are shifting in a really big way.
Okay, let's unpack this. Because to understand why the diagnosis process is changing so drastically, we first have to really understand the complexity of the disease itself. I mean, for a long time, public perception of endometriosis was basically just, bad cramps.
Yeah, that's a stereotype.
Yeah.
But clinically speaking, ACOG defines endometriosis as a chronic, inflammatory, estrogen-dependent disorder.
So definitely not just cramps.
Not at all. The core mechanism is that tissue, which is similar to the lining of the uterus. So the endometrium, it starts growing outside of the uterus.
I've always struggled to visualize how that actually happens. It's almost like seeds blowing out of a garden and then taking root in the sidewalk cracks outside the house. Like they're growing somewhere they really shouldn't be.
That's a great analogy, actually. And how those seeds get there is, well, there are a few leading theories in the source. One is retrograde menstruation.
Meaning backward flow.
Right. Instead of the menstrual blood and endometrial cells flowing entirely out of the body, some of it flows backward through the fallopian tubes and spills out into the pelvic cavity.
Oh, wow. So it just pools there.
Yeah. And those rogue cells then implant themselves on other organs like the ovaries or the bowel. But that backward flow isn't the whole story. The medical community is also looking closely at circulating endometrial stem cells.
Wait, circulating in the blood?
Yes, traveling through the bloodstream and taking root where they don't belong. There's also a really strong focus on genetic and epigenetic factors.
Epigenetics, meaning the environment is actually changing how the genes behave.
Exactly. Think of genetics as the piano keys you were born with, and epigenetics as the sheet music that tells your body how to play those keys.
I like that.
So certain environmental factors or cellular environments can switch genes on or off, which makes certain people highly susceptible to these rogue tissues implanting and growing.
Wait, I'm stuck on the estrogen-dependent part of the definition you gave earlier. If these misplaced cells are acting like the lining of the uterus, does that mean every time a patient has a hormonal cycle, these rogue cells are trying to shed and bleed inside the pelvic cavity?
Yes.
But the blood has nowhere to go.
That is the horrifying reality of it, yeah. These misplaced lesions contain elevated levels of estrogen and what we call pro-inflammatory mediators.
Which are what exactly?
You can think of them as cellular alarm bells. They're chemical messengers that constantly scream that there is damage. So the lesions react to the hormonal cycle, they bleed, they trigger an intense inflammatory response, and that inflammation creates this vicious feedback loop that promotes even more lesion growth.
Oh my God. Which means the body is just trapped in a state of constant internal alarm.
And here is where it gets incredibly dark for the patient. This chronic inflammatory state literally causes central nervous system remodeling.
Remodeling, like rewiring the brain.
Literally rewiring it. The persistent inflammation in and around these lesions acts almost like a fertilizer for nerve endings. It leads to peripheral nerve growth and sensitization.
So the nerves get more sensitive to pain over time.
Exactly. Over time, all those constant misfiring pain signals travel up to the brain and alter how the central nervous system processes stimuli. It physically lowers the body's pain threshold.
So the disease is literally rewiring the brain's pain response. That is heavy, and it perfectly explains why this is so devastating for you, the listener, to consider.
It is an all-encompassing burden.
Right, because if you have systemic inflammation rewiring your nervous system, it just destroys your quality of life. The clinical data emphasizes that this affects everything: sexual health, work productivity, romantic relationships.
And in adolescence, it's a major driver of school absenteeism. It really takes over a person's entire life.
Which makes the diagnostic delay we mentioned earlier, that 4 to 11-year gap, all the more jarring. So if it's causing the brain to literally rewire itself and the pain is that severe, why does it take up to a decade to get a doctor to write the word endometriosis on a chart?
Well, we have to look at the massive societal stigmatization of menstruation.
Right.
There is a deep-seated normalization of menstrual pain. People are taught from a young age that periods are supposed to hurt, so they delay seeking care.
They just think it's normal.
Exactly. And then when they finally do sit in an exam room, they hit clinical barriers. Clinicians often lack the nuanced training to recognize the varied presentations of the disease, which leads to doctors, dismissing, normalizing, or just completely misattributing the patient's symptoms.
I think it's crucial to point out to the listener here that this diagnostic delay isn't distributed equally across the board. The system fails everyone, but it fails certain groups much harder.
Oh, the equity gap is alarming. The guidelines cite a meta-analysis showing that Black women are significantly less likely to be diagnosed with endometriosis compared to white women. The odds ratio is 0.49.
Wait, 0.49. So they are essentially half as likely to receive the diagnosis.
Half as likely, yes.
And the text is explicit about why this happens, right? It's not like a biological difference in prevalence.
No, not at all. It is driven by racially biased, erroneous beliefs that have been perpetuated in medical education and clinical practice for generations.
Oh.
The delay is rooted in false beliefs about biological differences and racist assumptions that Black women have higher pain thresholds.
So a Black woman presents with the exact same debilitating pain, but because of biased medical training, the clinician doesn't even put endometriosis on the differential diagnosis list. They just dismiss the pain entirely.
Yes.
That is infuriating. And what about the transgender community? Because if medical textbooks traditionally frame this as a women's disease, how does that impact gender-diverse patients who have a uterus?
It adds incredibly complex layers of barriers. Transgender men and gender-diverse individuals face unique hurdles, starting with just the baseline misperception from doctors that endometriosis only affects cisgender women.
Right, just a complete lack of awareness.
Yeah. And on top of that, gender-affirming hormone treatments, like testosterone, can mask or alter the characteristic symptoms, making the clinical picture much more confusing for a doctor to interpret.
Plus, just navigating a clinic as a trans person can be a minefield of discrimination anyway.
Absolutely. The guidelines note that these patients frequently encounter misgendering and the outright denial of care. And a very specific trauma highlighted in the data occurs when a doctor wrongfully attributes a patient's severe physiological pelvic pain to gender dysphoria.
Oh, so they just say it's your dysphoria causing the distress and completely dismiss the underlying physical pathology.
Exactly. They ignore the physical disease. It creates a trauma loop that discourages the patient from ever seeking medical care again.
That's heartbreaking.
It is. What's fascinating here is that when you look at all of this, the decade of waiting, the gaslighting, the racial bias, the transphobia, it makes complete sense why patients react the way they do when they finally get an answer.
Because they're just exhausted.
Right. Once patients receive an official diagnosis, the overwhelming primary emotion they report isn't fear or sadness. It is pure relief.
Just validation.
Pure validation that their pain is real, that it has a physical name, and that it isn't all in their head.
So if the old gatekeeper, which historically meant waiting for a surgeon with a scalpel to visually confirm the disease, is what caused this biased, decade-long delay, ACOG essentially had no choice but to remove the gatekeeper entirely.
They really didn't.
Which brings us to the most radical part of this new guideline. We are moving into the era of symptoms as proof.
Yes. For decades, the absolute gold standard for diagnosing endometriosis was diagnostic laparoscopy. You had to go under general anesthesia, have a surgeon cut into your abdomen, insert a camera, and physically find the lesions.
So surgery was the ultimate bottleneck.
The absolute bottleneck. If you couldn't get a doctor to agree to surgery, or if you couldn't afford it, your treatment was stalled.
But this new 2026 text throws that bottleneck out the window. ACOG strongly recommends that a clinical diagnosis, meaning a diagnosis based purely on a patient's symptoms and a physical exam, is entirely sufficient to start empiric medical treatment.
Right.
You don't need to be cut open for a doctor to believe you.
Clinicians are being instructed to really listen to the symptom math. They're looking for specific, highly predictive signs. Chronic pelvic pain, dysmenorrhea, which is severe pain during menstruation.
Okay.
They're listening for dyspareunia, which is painful intercourse, dysuria, meaning painful urination, dyschezia, painful bowel movements, and infertility associated with any of those symptoms.
I really want to highlight the math on this because it proves why listening to the patient works. The source cites a massive study showing that having just one of those symptoms makes a person 5 times more likely to have endometriosis compared to a control group.
Yes, an odds ratio of 5.0.
A 5-fold increase from a single symptom, that should raise a red flag in any clinic.
It definitely should.
But listen to this, and this is for everyone listening right now. If a patient presents with 7 or more of these symptoms, the odds ratio jumps to 84.7.
It's staggering.
Think about that. If your body is sounding 7 different alarms, if it hurts to pee, hurts to eat, hurts to have sex, and you're in chronic pain, an odds ratio of almost 85 means the symptoms are screaming the diagnosis.
Screaming it.
A doctor shouldn't need a scalpel to validate a statistical certainty like that.
They really shouldn't. A symptom-based assessment is highly predictive, and relying on it allows patients to access relief years earlier. But obviously, doctors still want to use non-invasive tools to confirm what they are seeing clinically before they design a long-term treatment plan.
Right, you still need a plan. So if they aren't defaulting to surgery, what's in the diagnostic toolkit? Like what actually works?
The strongly recommended first-line imaging modality is transvaginal ultrasonography, or TVUS.
TVUS.
Okay. It's relatively inexpensive, it's accessible, and has high specificity. It is incredibly good at finding endometriomas, which are severe endometriosis cysts that form on the ovaries.
But TVUS has a blind spot, doesn't it? Like, a patient could get an ultrasound, be told it looks totally clear, and still have the disease.
Oh, absolutely. Because TVUS cannot reliably detect superficial peritoneal lesions.
Superficial meaning what, exactly?
These are flat lesions sitting flush on the lining of the pelvic cavity. They don't cast a shadow or create a distinct shape on an ultrasound the way a fluid-filled cyst does. So ACOG emphasizes heavily that a negative ultrasound does not mean you don't have endometriosis.
And a transvaginal ultrasound isn't physically or psychologically appropriate for everyone either.
Definitely not.
The guidelines are careful to note that for adolescents who haven't had vaginal intercourse, or for survivors of sexual trauma, a transabdominal ultrasound sewn done over the belly is the recommended alternative.
It's a real push for patient-centered care. And if the doctor suspects deep endometriosis, meaning lesions are infiltrating the walls of the bowel or the bladder, and they need to plan a complex surgery, they conditionally recommend stepping up to an MRI for better disease characterization.
Okay, so imaging has its place. But here's where it gets really interesting to me. We live in an era of rapid medical tests. We test for viruses at home in 15 minutes. We check blood sugar with a patch on our arm.
Right.
Why can't I just pee on a stick or get a quick blood draw to diagnose endometriosis?
I mean, it is the holy grail of reproductive health research, but right now it is a complete bust. ACOG issues a strong recommendation against using blood, urine, or endometrial biomarkers to diagnose the disease.
Really? Why are they so aggressively against it? If I'm a patient desperate for an answer, a blood test sounds a lot better than a decade of waiting.
Because the data is incredibly inconsistent and can actually cause active harm.
Harm? How so?
Well, the most well-studied biomarker is something called CA125. It's an antigenic glycoprotein found in the blood that often elevates when there is inflammation.
Okay, so if it's elevated, you have it.
Not exactly. An elevated CA125, so above 35 or 36 units per milliliter, might indicate you have endometriosis. But a normal CA125 level absolutely does not mean you are clear.
Oh, I see. It provides a false sense of security. It's essentially a coin toss disguised as science.
Exactly. If a doctor runs that CA125 blood test, sees a normal result, and confidently tells the patient they don't have endometriosis, they are sending that patient right back into the wilderness. The biomarkers studied so far just aren't as accurate as simply sitting down and taking a good patient history.
Wow. Which brings us back to the role of the scalpel. If symptoms are enough to start treatment, if imaging misses flat lesions, and if biomarkers are entirely useless, does diagnostic surgery still have a place at all?
It does, but its role has shifted from being the mandatory first step to being a shared decision between the patient and the clinician. You might choose surgery when the clinical picture is still really unclear and you need to rule out other acute pathologies.
Makes sense.
Some patients also strongly desire a definitive confirmation before starting long-term hormonal medical treatment. But there is another very serious reason surgery is utilized, and it has to do with cancer risk.
Yeah, we need to bring this up. It's a heavy detail from the guidelines.
Yeah.
Endometriosis is definitively linked to an increased risk of ovarian cancer.
Specifically, clear cell and endometrioid ovarian cancers. The text cites a massive cohort study of almost 80,000 electronic health records. It found that individuals diagnosed with endometriosis had a hazard ratio of 4.20 for developing ovarian cancer.
Wait, 4.2 us.
Yes, meaning they are more than 4 times as likely to develop it compared to the general population.
And that risk isn't flat across the board either. For patients with deep endometriosis or endometriomas, those severe cysts found on ultrasounds, the hazard ratio jumps to 9.66, almost 10 times the risk.
So if a surgeon does perform a laparoscopy, visual inspection of the lesions is never enough. Even expert surgeons can be fooled by how lesions look to the naked eye. Biopsies are vital.
They have to test it.
They need histological confirmation, meaning taking a sample of the tissue and looking at the actual cells under a microscope to definitively rule out malignancy. Though, ironically, a negative biopsy still doesn't completely rule out endometriosis if the surgeon simply missed the main cluster of cells.
Man. So the surgery is highly complex, it carries risks, and requires general anesthesia.
Right. And if we connect this to the bigger picture, this is why ACOG strongly advises a see and treat approach.
See and treat.
Yeah, if you are going to do a diagnostic surgery, the surgeon should be fully prepared to treat the lesions at the exact same time. It saves the patient from having to undergo the trauma and risk of general anesthesia a second time.
That makes total sense.
If you see the disease and you have the surgical expertise, you excise it right then and there.
So let's pull all of this together for you, the listener. What we've learned from this 2026 ACOG guideline is that endometriosis is vastly more complex than bad cramps.
So much more.
It is a systemic inflammatory disease driven by rogue tissues and a hormone loop that can literally lower your body's pain threshold by rewiring your nervous system.
And the historical 4 to 11-year delay in diagnosis is unacceptable. It is deeply rooted in societal stigma and erroneous medical biases, particularly affecting Black women and gender-diverse patients whose pain has been systematically minimized.
Right. And most importantly, the paradigm has shifted. ACOG is empowering patients by telling the medical establishment that a patient's symptoms are sufficient proof to start treatment.
Yes, the math backs up the pain.
You no longer have to wait for a surgeon to cut you open to have your reality validated.
It's a monumental step forward for patient-centered care.
It really is. But before we wrap up, I want to leave you with a final thought to mull over that builds on what we've discussed today. In the section on strategies to facilitate earlier diagnosis, the ACOG text briefly mentions the rapidly approaching future of artificial intelligence.
Ah, yes. The use of machine learning to parse complex medical data in endometriosis is a very active area of research right now.
The text notes that AI might soon be used to create predictive algorithms based purely on a patient's presenting symptoms and history. Basically, a computer will listen to the data, the dysmenorrhea, the dyspeunia, the years of chronic pain, and accurately predict the disease without needing an ultrasound or a scalpel.
It's a fascinating technological leap.
But it raises a deeply provocative question. Think about this. If a machine learning algorithm can validate a patient's pain, look at their lived experience, and accurately predict a disease based solely on listening to their symptoms, what does it say about our human healthcare system that it took centuries for doctors to finally do the same?
That is a powerful point.
Yeah.
That really highlights the difference between merely gathering clinical data and actually hearing the person sitting in front of you.
Exactly. If a machine can believe you without needing to see inside you, a human doctor certainly should be able to. Thank you so much for joining us on this deep dive. As always, take this knowledge, listen to your own body, and advocate for yourself, because as we've seen today, when your body sounds the alarm, you deserve to be heard. We'll catch you on the next deep dive.